Nice to meet you. My name is Yoshiki Takai from Tohoku University in Sendai, Japan. Today, I'd like to talk about pathological findings of IL-6 in the central nervous tissue in NMOSD. As you know, IL-6 is important in the pathogenesis of NMOSD. For example, IL-6 promotes survival of plasmablasts and stimulate the production of alpha-polyphenol antibody, and CSF levels of IL-6 correlate with alpha-polyphenol antibody and GFAP level, and which are higher during relapse than remission. Moreover, recent phase 3 randomized controlled trial confirmed that IL-6 receptor inhibitor reduces the risk of relapse in NMOSD. However, pathogenic role of IL-6 in the central nervous tissues of NMOSD remains unclear. So, the objective of this study is to clarify the deposition pattern of IL-6 in the central nervous tissue in NMOSD and review the possible pathogenic implications. We pathologically analyzed the central nervous tissue of 18 patients with NMOSD, including 8 alpha-polyphenol cell-positive patients, and using immunohistochemistry, we examined the staining pattern of IL-6 in the different stages of astrocytopathic lesions. This is a table which summarizes the clinical presentation of each autopsied patient. Pathological staging is variable from acute to chronic. This is the figure of IL-6 deposition in acute NMOSD lesions. There are a lot of perivascular alpha-polyphenol loss lesions with deposition of activated complement, which are the typical findings of acute phase of NMO. As you can see, lower left figures show that IL-6 are deposited at perivascular area and pia mater. In the high magnification images, IL-6 was seen in fibrous structure in the perivascular space, and this staining pattern is quite similar to that of IL-6 receptor and pericyte marker PDGFR-beta. This is the fluorescence double staining of IL-6 with GFAP or C9N. IL-6 staining of perivascular area was found not only in astrocyte destructive regions with complement deposition, but also the area where astrocytes are not impaired. This is NMOSD lesion with massive astrocyte loss, but existence of immature progenitor cells of astrocytes indicated these lesions are subacute phase of NMOSD. Unlike acute lesion, staining of IL-6 was seen at edge of the alpha-polyphenol loss area, and high magnification images shows that IL-6 is stained in a fibrous tissue similar to astrocytes. Further enlarged images of selected area, you can see that pattern of IL-6 is similar to that of GFAP staining. This graph shows that the relationship between the staining pattern of IL-6 and the pathological stage of astrocyte. IL-6 was observed frequently in acute and subacute lesions, but less in chronic lesions. Interestingly, IL-6 was predominantly deposited at the perivascular area in acute lesion, while in the subacute and chronic lesions, mainly detected in the surrounding tissue of astrocytopathic lesions. Here is the discussion. Both pericytes and astrocytes are known to produce IL-6, and alpha-polyphenol antibody could induce IL-6 production by astrocyte. In addition, exposure to IL-6 reduces Claudin 5 messenger RNA levels of endothelial cells and increased BBB permeability. Therefore, perivascular IL-6 expression enhances vascular permeability and accelerates the invasion of alpha-polyphenol antibody into the CNS. And as a result, tissue damage may be expanded by further expression of IL-6 by the antibody-activated astrocytes in NMOSD lesions. So, as a conclusion, our study showed that IL-6 deposition spread from the perivascular space to surrounding tissue of NMOSD lesions as time proceeded, suggesting that IL-6 may contribute to the lesion development. Thank you for your attention.